It's a huge push to identify patients at early and more treatable time points. Unfortunately, we haven't come up with a cure yet, but we think that if we can find the right people who are at risk of developing Alzheimer's disease, then we can put them into better trials and then hopefully come up with a therapy. So I think that has been the theme of all of CTAD is blood-based biomarkers identifying patients early. And so our study was essentially in line with that. There is a study known as the A4 study. It was initiated in 2014, and it was the first of its kind secondary prevention trial where they were intentionally enrolling older asymptomatic individuals who had amyloid deposition as measured by PET scan. And they also had clinically normal adults as well, too. So these were asymptomatic, no signs of cognitive impairments. However, they had amyloid in their brain. So we wanted to utilize the plasma that was collected from those patients, and we wanted to see if we could use a blood test to predict if they would have come up amyloid positive or not. So we had a very small, so these were A4 trial participants, small sample size, and we recognize that we only had about 200, a little over 200 patients. And so in this specific study, not only we were trying to predict amyloid PET positivity, we also wanted to assess how accurate or how sensitive these measurements were by going through two different companies. So we used C2N's platform to measure different amyloid biomarkers. The most notable one was the classic ratio A-beta 40 to A-beta 42. And then we also used the company Shimatsu, which was in Japan. So we wanted to compare if both of their assays were comparable. And then a second internal comparison that we wanted to do was assessing plasma processing. So when you collect plasma from a patient, there's a time window for, when it's received, when it's taken from the patient and when it's received to a lab for processing. Our standard protocol is 2 hours, but sometimes you can't process plasma within 2 hours. There could be some sort of extenuating circumstance. So we wanted to do a test to where we actually had an aliquot of the same patient's plasma, and we processed it 24 hours later. So we again wanted to see, were our assays able to predict amyloid positivity based off of this plasma test. And then we wanted to see if there was a processing time, if the processing time impacted those results. And so what we had determined was that there are some effects with sample pre-processing, and we found that amyloid ratio A-beta 40 to 42 is a good predictor of amyloid PET positivity, as well as the time to process. So 2 hours does appear to be more effective and more efficient at in this process in regards to 24 hours. Well, so the first study is absolutely to increase our sample size. So as I said, we only had 200 patients, and keeping in mind, we were doing kind of those inter studies. So we wanted to keep the sample number small in order to make sure that we could handle all of the plasma. But now we want to expand that. We're going to be exclusively working with C2N in order to get more samples processed, and to see if we can really kind of increase the evidence that plasma A-beta 40 to 42 or any of the other amyloid measures can actually be used as a suitable biomarker for predicting amyloid PET positivity. And then there are some other studies that we've been seeing even at this meeting this weekend, is that we're actually trying to move earlier in the patient group. So there's a new study known as the AHEAD study that's recently come out in the next couple of years, and they are essentially trying to move earlier in the disease progression, and they're doing that based off of the centiloid count. So that's kind of like the arbitrary measurement for determining how much amyloid is in the brain. So the patients in our A4 study, they had what we would consider to be on the higher level of centiloid. So it was pretty evident that that there was amyloid in their brain. But what happens if you have a patient who is between 20 and 40 centiloids, who are on the lower end, who are probably just starting to accumulate that amyloid in their brain? Can this same measurement actually also pick that up and still be able to predict amyloid PET positivity? So that's actually more of a future direction. So that was also a theme that was well advertised and identified in this conference, that ethnicity was not a part of this study. Traditionally, a lot of clinical trials have difficulty enrolling minority patient groups. In our study, looking just at African Americans, we had less than 4% of our patients were African Americans. Latinx, those patient groups tend to be a little bit more representative, but still not as much. So our study, in total, we had 95% non-Hispanic whites. So there was no ethnic diversity in our study, and that seems to be a common thing. But I also think now people are way more invested in recruiting minoritized groups, factoring into these analyses, because there are studies that are showing that not all minoritized groups are responding the same. And if we think about treating the world, we can't just base everything off of a non-Hispanic white.